class. My name is Faith Jimenez, and I'm a DNP specializing in family practice at University of Maryland School of Nursing. GI disorders are one of my favorite topics because I used to be a surgical ICU nurse, and where a majority of our patients have had abdominal surgeries. So today I will talk about evaluation and management of acute abdominal pain with emphasis of appendicitis in primary care. Okay. So abdominal pain is one of the most common and challenging chief complaints in both adults and pediatrics in primary care. There are many causes of abdominal pain, such as, but it is the provider's priority to be able to differentiate whether the patient is indicated for an emergency referral. So the goal of this lecture is for you to be able to identify the types of abdominal pain, describe the symptoms including red flags of appendicitis, and describe the special tests when examining for appendicitis. So what is abdominal pain? Abdominal pain can be defined as a sensation of discomfort, distress, or agony in the abdominal region. So I just have a little illustration where it shows the complex organs that's included in the gastrointestinal area in the abdominal region. So the etiology of abdominal pain can be organic or disease-based. So it means that it can result from anatomic, physiologic, or metabolic or inflammatory causes in one of those organs. The non-organic or functional type of abdominal pain it means that there is just no clear cause of the pain. So an abdominal pain can be acute or chronic, and there are three types. It's either visceral, somatic, or referred. The visceral abdominal pain is an inflammation or injury in the actual organ. So it is described, the pain is usually described as constant, dull, cramping, and poorly localized. Somatic is an inflammation in the lining of the peritoneum and is characterized by sharp and well-localized pain. Whereas referred pain is characterized by pain radiating from an area outside of the abdomen. So abdominal pain is the second most common diagnosis in outpatient visits. Up to 25% of adult population will experience it in their lifetime, and in the pediatric population, up to 9% of primary care visits are because of abdominal pain. And in the emergency department visit, in pediatric, 10 to 30% need surgery if they come in for abdominal pain. So this is just an illustration, a diagram that illustrates the types of abdominal conditions that you may have based on the location. So that's why it is important to ask the patient what is the location of their pain. Especially in the pediatrics, you want to ask them or have them point to the location of their pain, as younger patients usually have a harder time in describing their own pain. So now I'm going to talk about appendicitis. It is the most common acute abdominal pain diagnosis in primary care. It is an acute inflammation of the appendix wall due to fecal blockage of the lumen, resulting in distension and bacterial infection, and could lead to gangrene and perforation, which is an intra-abdominal emergency. So about approximately 300,000 appendectomies happen annually in the United States due to appendicitis. The incidence of developing appendicitis in one's lifetime is approximately about 7 to 14%. And appendicitis usually happens between 10 to 19-year-old patients and in their late 40s. And it usually happens more in males than females. So here are the following symptoms and diagnostic studies that can be used for diagnosing appendicitis. I bolded the ones that are red flags. So symptoms for appendicitis include low-grade fever, pain, pain that is sudden onset and severe, pain that starts from the periumbilical area that migrates to the right lower quadrant area, and pain that wakes up at night. So low-grade fever, migration of the pain, and pain that wakes up at night those are the red flags for appendicitis. Nausea, vomiting, diarrhea are added symptoms that could help you diagnose appendicitis. As far as diagnostic studies, those are the following needed to diagnose appendicitis. Complete blood count with differential will show an increase in white blood count or leukocytosis. It's just indicating inflammatory process. Imaging studies include CT of the abdomen and ultrasound. CT is the preferred modality as it demonstrates the highest diagnostic accuracy. So in the CT scan, it will show an enlarged appendiceal double wall thickness and appendiceal wall thickening. As far as the ultrasound, it's usually reserved for the pediatric and pregnant population because of the lack of ionizing radiation compared to CT. So we're going to talk about how to ask or what to ask a patient when they come in for abdominal pain, and specifically geared towards diagnosing appendicitis. So a thorough history of present illness is needed to be asked. So old cards is a mnemonic that clinicians use to ask about the pain. It stands for onset, location, duration, character, associated or alleviated factors, radiation of the pain, and what does the T stand for? Is that?
Timing.
There you go. And S? Severities. There you go. Good. Alright, so let's start with onset. What would you ask about onset of pain? Or what is the first thing to ask when the patient come in for abdominal pain? Go ahead.
When did the pain start?
Good, yeah. So it's important to differentiate between acute and chronic pain. So acute pain, when they come in, they're saying they've been having abdominal pain. How long? How long have they been having this pain? Is it acute or chronic pain? Ask the patients to rate their pain from 0 to 10 using a numerical scale. And for pediatric patients, ask them to rate, you can use the FACES scale. So they can, use the diagram to tell them your pain. Next, ask for, what's the next, mnemonic L, location. How would you ask for, what question would you ask for location? Go ahead.
Where on your stomach does it hurt, or where on your body does it hurt?
Yeah, perfect. Yeah, that's why I showed you that diagram earlier. Ask them which part of their abdomen is hurting. It usually says, which organ is affected with the pain. All right. So duration. What question would you ask for duration? Yes?
How long does it last?
Good.
Or maybe how is it constant or intermittent?
Yeah, there you go. So it differentiates. Is this something that's happening all the time? Is it an on and off pain? So these are questions that really it really delves into further into the patient's pain. All right, next, character. What could be asked for the character of the pain?
Is it sharp, dull, aching, cramping, throbbing?
Perfect. Good. Those are characters of pain. So you want to ask. Remember, I discussed about earlier the 3 types of pain: the somatic, visceral, and the referred. So character of the pain helps the clinician or the provider differentiate between those 3 types of pain. So So good job. You want to talk about associated factors, relieving factors, or radiation of the pain, like we discussed, timing and severity. You also want to ask about, how old are they, what's their gender. Further, you want to ask about allergy history, medications they're taking, any medical or surgical histories, family and social history. So the review of systems is an inventory of specific body systems performed by the clinician in the process of taking a history from the patient. It is designed to bring out the clinical symptoms which the patient may have overlooked or forgotten. So these are each system that you want to ask. In general, you want to ask about have they had any fevers or chills. Fever could indicate like an inflammatory process in the body. I want to delve into the gastrointestinal system, ask them about, the old cards of their pain, any appetite changes, any nausea, vomiting, diarrhea, things of that nature. Okay. Physical exam. So a thorough physical examination must be performed. You want to assess their vital signs. Are they having tachycardia? Are they febrile? Are they having fever? Are they hypotensive? Those are indicators that your patients are, like I said, having an inflammatory process. The rest are the systems, but I wanna for any physical assessment you wanna assess for their cardiovascular and pulmonary. You wanna always auscultate their heart and lungs. But I wanna go really delve into the gastrointestinal system. I'm using this process, the IAPP, for the GI system. You want to inspect, auscultate, percuss, and palpate in that. You want to use those four steps in that manner. So first, you want to inspect the abdomen, look for the skin, and any bruising, any rashes. Then you want to listen with your stethoscope. Auscultate the 4 quadrants for bowel sounds, using your diaphragm first, and then next you want to auscultate for bruits in their arteries using the bell. Then next you want to percuss all quadrants for any fluid or gas, any distension or solid masses, and lastly you want to palpating all quadrants for any tenderness, any distension, any enlargement or hernias. Next, we're going to talk about the special tests. These are special evaluation techniques that can help the clinician localize the inflamed appendix, and I'm going to use the video to show you that.
A positive psoas sign is another indicator of acute appendicitis. The appendix lies close to the iliopsoas muscle, so if the appendix is inflamed, any maneuver that tenses or stretches the iliopsoas muscle may result in increased right lower quadrant pain. There are 2 ways to test this psoas sign. One way is to have the patient try to flex the right hip by raising the right leg against the resistance of your hand. Tom, I'm going to have you raise your right leg against my resistance, and let me know if you have any pain. The second way to test the psoas sign is have the patient roll onto his left side, then grasp the right leg and extend it at the hip. This stretches the psoas muscle. Increased right lower quadrant pain with either of these maneuvers is a positive psoas sign. Tom, I'm going to have you roll on your left side. And I'm going to extend your leg and let me know if you have any pain with this. And turn back over on your left.
Okay, so that was the psoas sign special technique. Next, I'm going to show you the obturator sign, and I'll show you that with a video as well. Oops, let me close that one, sorry.
The obturator sign is another sign of appendiceal irritation. The internal obturator muscle lies close to the appendix on the right. When this muscle is stretched in the setting of an acute appendicitis, the patient experiences increased right lower quadrant pain. To perform this test, flex the patient's leg at the hip and the knee, then internally rotate the hip. This stretches the internal obturator muscle. Okay, Tom, I'm going to flex the knee and the hip and internally rotate and let me know if you have any pain with that.
All right. So those are the two special tests that can be used in when examining and trying to help localize and diagnose the appendicitis. Oh, I'm sorry, let me close that out. There you go. All right. Next, we're going to talk about how to manage appendicitis. So according to the Infectious Disease Society of America, or IDSA guidelines, both antimicrobial therapy and emergency appendectomy within 24 hours of onset of symptoms are the guidelines, what guidelines suggest for you to do. So, let's see here. So you want to do those things. You want to initiate IV antibiotics right away, and admit them to the ED to prevent peritonitis or perforation within the 24 hours of onset of symptoms. The risk of perforation increases, can reach up to 36% after 36 hours of onset of symptoms. So the longer you wait, the higher the risk of complications of appendicitis. So because of technological advancement, it used to be open appendectomy. Now we do laparoscopic appendectomy. It is the preferred approach compared to open procedure because it decreases the rates of complications. In the US, 60 to 80% of cases of appendectomy are performed laparoscopically. And like I said, it has decreased rates of complications. Another treatment modality is just antimicrobial therapy alone for those that have an uncomplicated appendicitis, no other comorbidities. But studies have shown that there are higher recurrence rates of appendicitis, which is about 10 to 37% recurrence rate. And that is my presentation on evaluating abdominal pain with emphasis of appendicitis. Any questions, class? Good. Thank you for having me. And these are my references. Feel free to email me for any questions, okay?